Yeah. We're now live.
Thank you indeed. Thank you. Okay, well, good evening, members, and welcome to the Adult Health and Social Care Scrutiny Board on Thursday, the 18th of November, on a very dark, dismal, and very damp day. So let's liven up the atmosphere. We've got a few new people here tonight, so a very warm welcome to them. We're just going to ask them to do a slight introduction to themselves. So if I can start off with Michelle Wright, if you'd like to unmute yourself and say who you are and where you're from. It's like a destination, isn't it?
Good evening, members. Thank you for introducing me, Howard. My name is Michelle Wright. I'm one of the 3 business relationship managers that works with adult services. We all 3 of us have a portfolio which covers all of the borough in terms of any adult provider that contracts with us as a local authority. So currently my portfolio is for services in the Lower Valley, in Calderdale, and also Calder and Ryburn, which is South Halifax.
Super. Thank you very much for the introduction, Michelle. That's extremely helpful. So if I can go on to Isma Amjad, would you like to introduce yourself and say a very warm welcome to yourself, of course?
Well, thank you. My name's Isma. I've been working for Mrs. Nisi at Valley View Care Home for a number of years. I'm currently training to become an assistant manager. And throughout COVID, I've worked alongside Beverly.
Excellent. Well, good luck with the assistant manager position. I'm sure you'll be very successful. So we can go on to Jennifer Freeman Hudson. Would you like to introduce yourself and welcome once again? Just unmute yourself. You're just on mute, I'm afraid. Sorry. There we go.
Okay, good evening, everyone. Thank you. My name is Jennifer Freeman Hudson. I'm co-owner and deputy manager of Angel Wings Home Care in Brig House.
Thank you very much for the intro. We know Neil Smithwaite's, but welcome anyway, Neil. Jill, would you like to just come on camera for a few moments? Hi, Neil.
Good evening, everyone. I'm Jill Holden, the Assistant Director for Commissioning and Partnerships.
Super, thank you very much. Neil, I'm going to go back to you. I didn't mean to miss you out, so do an introduction to everyone because you are important.
Thank you, Councillor Blackburn. I'm Neil Smithwaite. I'm the Chief Operating Officer for the Calderdale Clinical Commissioning Group.
Thank you very much. And Rachel Bevan, so welcome, Rachel. Just a small intro, if that's okay, please.
Thanks, Chair. Yes, good evening, everyone. I'm Rachel Bevan. I'm working as Programme Manager for Place-Based Partnership Development in Calderdale. Bit of a mouthful, but...
we use the mouthfuls on this committee, so thank you very much for that. I think everyone else... Debbie, welcome, Debbie Graham. If you'd like to just do an intro once you're connected. I know you're just connecting at the moment to your audio, so we'll just lengthen the intro for yourself so that you can get in. I'm sure... Good evening, Debbie, and welcome. Just if you'd like to just introduce yourself and who you are and where you're from.
Hi, Debbie Goodall. Was Debbie Goodall. Don't know where that came from. Debbie Graham from Calderdale CCG.
Thank you very much indeed. Okay, superb. Right, if you want to raise a question, there is a reaction button on the bottom. And you can raise your hand, and I'll take you in order as I see you as appropriately. So if I don't quite get the right order, my apologies. So let's get on to the agendas. So substitutes nominated for this meeting and apologies for absence. We've got no substitutes. And everyone is
Chair, and no apologies.
Fantastic, superb. Item number 2, members' interest for members to declare the interest at the relevant time. Item number 3, admissions of the public. The public are most welcome to watch on YouTube, so welcome anyone that is watching. You always find this is one of the best meetings to watch if you are an outsider, so welcome anyway. So item number 4 is minutes of the Adults Health and Social Care Scrutiny meeting held on the 21st of October and equally the 26th of October is my understanding. Councillor Hutchinson.
Just got an amendment I think is needed in the minutes from the 16th of September. And minute 31, the first bullet point, I think should state health, that 1 in 5 transmissions of COVID have taken place in healthcare settings, not in care settings.
Sorry, can I just interrupt? You're talking about minutes for the 16th of September, Councillor?
That's right. That's right.
We're looking at minutes for the 21st of October and the 26th of October tonight.
Are we? Okay. Sorry, I was looking at the ones.
They were misprinted on the agenda. It said on them.
Okay. Well, it's the one.
The October ones.
The October one, yeah.
Yeah.
So where it's minute 31.
Which minutes are they for? 21st of October or the 26th?
No, these are going back to the 16th of September. These noticed, I think, so I must admit, I printed off the 16th of September originally. Okay. But I think those have been approved. But it might, I don't know if you can put in an amendment with the 16th of September ones.
Right. Okay. It was just the ones that were attached to the calling papers.
Indeed. Councillor Kingston, would you like to raise a question? You just unmute, I'm afraid.
Sorry, thank you very much. The 26th of October, that's the call-in, correct? Yes. Yeah. It was at the beginning of the minutes where it says about Councillor Josh Fenton Glynn spoke about having surveyed businesses in Hebden Bridge, and I felt that was inaccurately reported what he said in the minutes because it gives the impression that a ban on A-boards wasn't popular with businesses in Hebden Bridge. What he actually said was that it wasn't universally popular, which is a very different thing. Thank you.
Okay, no, thank you for those. So with that slight amendment, can we take those as a true record? Can I have a proposer and seconded? Sorry, Mike, would you like to come in on that?
Sorry, Chair. I do think that the minutes that Councillor Hutchinson was referring to was in the October discussion.
Well, it's not dated, is it?
Well, it refers in there to having agreed for that meeting that the minutes for the 16th of September were agreed. You couldn't have agreed the minutes for the 16th of September on the 16th of September.
I think there's an error in the date on the minutes, but I think Councillor Hutchinson is correct that it was discussed at the last meeting. Excuse me.
All right.
So that amendment needs to be put forward. Councillor Swift.
Yeah, I think I'm being dense. I do apologise. I've got 2 lots of minutes, but I don't think they're the right one. I've got one from 16th of October. Then we have another one, but I haven't got the October ones, I don't think. Did that just come through on the email by any chance?
Would you like to just come in and just explain where everything is? I think we've been confused in terms of that. Right. Yeah.
Okay, there was an error apparently when the agenda was circulated and published. It says it refers to 2 days in August, which is the 21st and the 26th. The date is right, the month is wrong. In October, on the 21st, we will have, or the panel will have approved the 16th of September minutes. So tonight we are looking at the 21st of October, which was circulated with the agenda, and the 26th of October, which was circulated earlier today, I understand.
That's my understanding too. So on that basis, Mike, have you still got your hand up for some reason?
Only to reiterate that the minutes that were circulated, the minutes that were circulated with the agenda are the minutes for October, even though they say September on the top. They are the October minutes. So one of the things that needs to be corrected is the date on that document.
Right, sorry, I'll look at the dates on the top of those then and make sure they get corrected.
So it comes back to Colin, Councillor Hutchinson's point that actually item 31 needs to be amended in that case. Right. I'm totally confused because my minutes equally said the 16th of September on the top of them. So we got there eventually. It doesn't normally take us this long to get through. People are joining us for the first time. So on that basis, can we propose and second those? I'm happy to propose them on that with those slight amendments. Councillor Hutchinson, you okay to second? Yeah. And all in favour? Just show of hands. Yeah. Perfect. Right. Excellent. Okay, that took a little bit longer than what it normally does, but we've got there. So, item number 5, support to health and care staff. It's the lead on this is Ian, but we've got various people that have come along as well. Ian, would you like to just add anything to what we've already got in front of us?
Thank you, Chair. Jill is going to take you through a very headline presentation just to get us focused back onto what particularly health, social care staff, particularly in our commission services, have been doing throughout the pandemic. I know that as part of the scrutiny in a day, you were really particularly interested in ensuring that you had further updates on the physical and emotional well-being of staff who've worked so hard during the pandemic. And we thought Jill would talk you through the kind of headline presentation, but more importantly, we spend more time listening for people who were much nearer the front line of providing direct care to how staff have been resilient and supported through the whole of the pandemic. So I won't say very much because I think it's more important that you probably hear from people who have been directly involved nearer the front lines than myself. So if Jill's ready to kind of press the button on the presentation, she'll talk you through the presentation, but then we'll hand you over to Michelle, who's introduced herself already, Isma and Jennifer.
Brilliant, thank you. Welcome, Jill. You did it the first time, so let's do the presentation.
Thank you, Chair. Good evening, everyone. As Ian's just said, I'll take you through a very brief overview of the report and then hand over to the providers, because I think that will be much more interesting for members to see. So Ian's just very briefly there presented the reason why this report's come to Scrutiny Board this evening. And I think the key things for me to present is pre the pandemic, the workforce position in Calderdale had been relatively stable, but we are now starting to see some shift in terms of the true impact that the pandemic has had on the workforce. I think the report really highlights that there's more to do to ensure that our provider care staff in social health and care are better recognised, and that pay and conditions are more on parity with other sectors such as retail and hospitality. And in terms of support provided to the provider workforce throughout the pandemic, the Council, Public Health, CCG and voluntary and community sector have all worked in real partnership to ensure a comprehensive package of support for staff health and wellbeing. So physical well-being, I've just highlighted here the value of the PPE that's been provided, and that's all been really in relation to the physical protection from infection for the workforce. And you'll see there that we've distributed a significant number of items to providers. Public health, infection prevention and control have had a real critical role in developing confidence of staff and providers in how to use that PPE, and actually the regular translation and interpretation of guidance in terms of the terms for donning and doffing of PPE and super training provided in regard to that, particularly at the beginning of the pandemic. hopefully people will be aware that from the 11th of November, all people working in CQC registered care homes are now required to be fully vaccinated against COVID. There's been a significant emphasis, piece of work taking place through all sectors really to support the uptake, and you will see there that in older people's homes we've got an uptake of 98% across both older people and learning disability care homes, which is a good uptake rate. And that's with the exception of obviously a small minority staff that may be medically exempt. Just some nice quotes here. So whilst we've provided measures such as funding through government Department of Health and Social Care, some quotes there around how staff might have benefited from taxis, for example, for travelling to and from work to keep them free from infection from travelling on public transport. As some providers have bought in pool cars for staff who can drive but don't have access to a vehicle, and some staff who've chosen to live away from families to keep residents safe. There's been measures such as paying for their accommodation costs. In terms of emotional health and wellbeing measures, I won't list them all here, but there's been a whole range of access to universal and targeted services, a range of free yoga and other therapies provided, support helplines, and a quote there at the end of how staff have valued that provision. Again, I won't labour on these, but just some comments that staff have made about the services they've received in terms of emotional health and well-being and the personal benefit to them. And similarly, some more quotes here around experiences that they've had and how that has improved their well-being. Pay and benefits. The provider fee uplift for 2021-22 included an additional 2.6% to enhance the pay workers, to bring that to £9.21 per hour in line with the low pay commission rate. We know there's still a long way to go, but I think that is just a message from the council in terms of our aspiration to ensure that we can try to work towards an improved pay offer for those staff. And then some individual recognitions from providers around vouchers, for example, thank yous, because valuing staff and ensuring they're recognised for their work has been critical. And then just lastly, some wider measures. So there's been designated testing areas for staff in some workplaces, designated changing rooms, additional uniform provision, laundry facilities. There's been enhanced care home support teams going into homes to target interventions. Recruitment is a real challenge for providers at the moment. So we've been supporting developing a staff bank, been supporting enhanced care home support teams going into homes, and recruitment initiatives, looking at how we can support providers in their recruitment of staff. And then lastly, these people have already introduced themselves at the start of the meeting, but I'm now going to hand across to Michelle Wright, the Business Relationship Manager, just for her to spend a few minutes talking about her role in supporting providers, and then she will hand over to Isma and Jennifer. Thank you.
Thank you, Jill. That's most helpful presentation, quite useful, extremely useful as well. So thank you for unsharing your screen. So Michelle, say once again, welcome to our Scrutiny board. The floor is all yours.
Thank you very much. Care staff at all levels throughout the pandemic have demonstrated remarkable resilience and dedication to deliver the best possible care for service users in our borough. The impact of the pandemic on the staff wellbeing, as Jill has mentioned, both in the short and longer term, should not in any way be underestimated. a number of staff that we've been working with throughout the pandemic, particularly when sadly homes have had outbreaks, has really taken its toll on everybody within the service, and also colleagues that have been in there supporting services through these very difficult times. As Jill mentioned, a number of agencies have reached out to the services, and we've encouraged the uptake of that support for people, for individuals of staff, but also residents and families who are part of the services, in recognition of the pressures and the support actually that people have needed and have continued to face and have struggled with, particularly when we've had loss and bereavement in services. We've got increased stress levels, exhaustion and burnout. During the outbreaks of COVID, for services, it's been a vital element around supporting the workforce and individuals who are utilising the services to ensure that they've got the connections and the support around their emotional health and well-being. It has been difficult in some situations for staff to reach out to that support because they've seen it as a failure on themselves, and this is just something they say to us that they should be able to deal with. But again, you know, the pandemic has taken extreme tolls in so many ways. So staff need to be given the time, the space, and ultimately the resources, which again is one of the big issues at the moment in terms of recruitment to support services. But in order to get good care and improve retention of staff, that investment is vitally important to ensure that we can support with recruitment. The authority, again, as Jill mentioned, is looking at a number of initiatives. We're currently working with the comms team as well to develop a local recruitment campaign, which links in with the national initiative that's currently ongoing, because as we know, this is not just exhaustive to Calderdale, this is across the country. We're also working with providers to share quotes and experience around their time during COVID, around their experience, so that again, this can be shared with people who are interested in a career in care, so that we are setting those expectations, because again, it's not fluffy slippers, this is hard work and very, very challenging and extremely exhausting for people. But a career in care, by sharing those examples and values and opportunities, will hopefully encourage people to think about, is this something I can do? Often we hear that, well, I don't have any experience working in care, but as we know, people have cared for loved ones, for elderly parents, maybe for disability. So that is an experience in care, but then we can mold that and shape that and help people to understand that actually they've got the values that we need them to come and work in care. Another initiative that we're working on, which is again in its very early stages, is looking at a web page centrally, so that any opportunities that services may have in terms of vacancies at the moment, of which is a number, but we want to be able to collate that and share that so that it's a central point for people to be able to access. The Eye Care Ambassador, we've recently had some events in the borough which people may or may not be aware of, which has focused around the markets. So that's across all the borough. And we did this in September and October as business relationship managers, linking in with workforce development and crucially our providers as well, who came along and they were able to talk about what their service looks like, the opportunities that they have, and again share what it's like with people in the communities around the opportunities that are available for a career in care. It's very, very difficult, particularly as business relationship managers, to hear some of the stories that we have sadly heard during the outbreak period, and continue to hear around how services are struggling to retain and recruit. We talk about values-based recruitment, and we try to get people from all diverse backgrounds, opportunities, to have a look at what a career in care may look like, because there are jobs available for people. So we are working very hard with partners in schools and colleges and local groups as well, to raise the profile around working in care, and hopefully help to encourage people to think about, is this something I can do? Can I work in a care home? Can I work in domiciliary care provision and make a difference to the people of the borough? But by no means are we out of the woods, as you might say, particularly as we are approaching winter pressures. The needs and support required by people in the borough is ever increasing, and sustaining a workforce that's sustainable and can provide that level of support is very, very challenging, to say the least, at this moment in time. But we have two providers with us this evening who have, one of which has sadly come out, well, thankfully come out the other side of an outbreak, a residential care home, Valley View, at the top end of Pelham. And then we also have a domiciliary provider who is based locally in Brigg House as well. So at this point, unless anybody has any questions for me, I'd like to hand over to Isma at Valley View.
Thank you, Michelle, and thank you for the comprehensive overview. I think it's really at this stage to give a formal thanks to all the frontline staff, to pass that on to the people you meet. It has been extremely challenging times, and we recognise that the hard work that has been going on in the background in the care settings. So on that, I'm going to ask Isma to give a brief overview of what she's experienced and things. So thank you.
Thank you very much. Yeah, first of all, I would like to apologise on behalf of Beverly. She can't make it here today. Right, so obviously during our outbreak, we've had a lot of pressure and there's been a lot of challenges. But thanks to the local authority and to Michelle Wright, our business relationship manager, we've actually managed to get through this. Because without the help, I don't know if we would have been able to. I mean, the funding helped us get through all the staff that were off due to COVID isolation. It helped us with our PPE just so we could meet the IPC requirements. Staff, we had to get agency staff in because we were low on our staffing levels. Beverly paid for our taxis and made things quite easy for us at such a difficult time. She obviously gave us all the support because Beverly worked alongside with us. And then obviously a big thank you to Jill Holbert, who made daily calls to ensure that we got all the support that we needed at the time, and which really does mean a lot when people ring you up and everything. And then going on to the staffing, I mean, we lost quite a few staff at the time. The agency staff came in, which was a bit difficult when new staff are coming in and everything, but we did get through it. We got through it really, really, really well. Yeah. But the current challenges that we are finding right now are actually around the staff that we've lost due to the vaccine. So luckily, we've only lost a couple of staff, which is not too bad. But again, the recruitment is a bit difficult. Although where everybody is doubly vaccinated right now, it's a shame that we've lost two really, really good members of staff. Yeah, and during the outbreak, like, we were constantly working. The staff were absolutely great. They worked through without breaks. Some of them gave up their holidays. And yeah, it was a difficult time, but we got through it. Definitely got through the whole thing.
Excellent. Thank you for that. I think that's really useful to share that information to members on the panel. I think that's extremely useful, and we really recognise the difficulties and the challenges that you've had to overcome, and it is thanks to the sports as well in the background. So Jennifer, can I bring you in at this stage from Angel Wings Home Care? So
absolutely.
Can
you hear me?
We can indeed.
Okay.
Yeah.
Lovely. Well, firstly, thank you very much for the recognition. Much appreciated. The support Angel Wings has received has been invaluable. It has enabled us to continue to provide our usual high standard of care in these uncertain and scary times. Tears of panic have been down the phone to our relationship manager, Michelle, as we were effectively having to turn our backs on our own family to care and protect other people's safety. And each and every time we were picked back up with genuine care and advice. And if Michelle or Trish had no answers for us, they would find out and call us back. We received daily calls from Anne during the beginning of the pandemic. We grew very fond of her, and she made it very clear that we could contact her anytime, which at points we did off spec often. In regards to obtaining information around COVID-19 statistics within our company, this was requested in a kind and patient way. The people who were requesting this information knew we were under pressure, and regular thank yous for our dedication were often circulated, which is highly appreciated. We feel the Infection Control Fund was coordinated and accounted for extremely well, and any money that our company did not spend was given back. This money has been a huge help, and I genuinely feel that without it, we probably wouldn't be here. It's evident from our experiences and our outstanding CQC status that the council not only do a job, they personally provided us a service that strives to better the community and the care for the people within it. Through the years, we're wonderful people from the council and had some inspiring conversations that stem from inspiration, not dictation. This has enabled us to keep our team of angels strong, focused and safe. The extra money given to pay our staff certainly helped with morale and job retention. We all know it's a poorly paid job for the sacrifice they have and continue to make, but it's my understanding that the council have financial targets for this, so I'm hopeful this will change in the future. We were made aware of emotional help available from counselling to massages, and we were encouraged to use it via regular informative emails and phone conversations, which we ensured were passed on to our staff and utilised. In regards to staffing issues, we have not experienced any on a detrimental level to our service users. However, our management team have found ourselves covering more and more care in recent weeks and now form part of the rota system, which is not sustainable long term. We have more work to do in the area of recruitment, and the council have kept us informed of any recruitment events and sent links to websites that could help. Michelle rings us often to see if we need help in this area. To conclude, I would like to tell you all that during the pandemic, I can honestly say from the heart that Angel Wings have been supported both financially and emotionally. Without the help we received, we may not still be here, and that would have been a very sad loss for the care sector of Brighouse. We are very grateful and want to publicly give our thanks to you, Calderdale Council. So thank you. If you to ask me anything specific, please do.
Thank you ever so much. It's really a wonderful insight, and being a Brighouse-based company even better. So thank you for that and the support.
Thank you.
Right, I'm looking around members, see if they've got any questions. We do. Councillor Swift.
Thank you. Before I comment, I want to know that everybody knows how hard you've all worked, and it's a bit frightening how hard you've had to work to get through this. But any comment about any of the systems isn't a comment about staff or care home owners and one thing or another. It's just a way of trying to clear certain things up in different people's minds. One of the things, I've got a friend who works in a care home, and I had the joy of having 3 or 4 of them visit. They did eat a lot, and I weren't expecting them, but that's beside the point. They were all glad they were in the care system, but there was they were working more hours than they were comfortable with. They accepted the care home, didn't have any choice, but they were working, and they were obviously there by themselves on occasions. And you know, it makes it difficult. I take into account what was said about the £9 something. I mean, if somebody could tell me what the difference between that is and the National Health Service, it would be useful for me. And I think when we talk about home care, is that when you, right, the person I know hasn't got a car. So she takes longer to get from A to B, which seems to me it's less time with the whoever you're looking after. That point at one turn wasn't paid for. I'm hoping it is now, but if you've no money, I accept that, you know, can't do anything about it. But I would like to think that as we move forward, and life's very difficult for everybody, we can find a way of making it so financially anyway, it's possible these people who are good at what they do and want to continue doing it can. Thank you.
Thank you, Councillor Swift. Ian Baines, would you like to come in on that?
Yeah, I think there's quite a lot in what Councillor Swift has raised, and I'll try and address most of that. So I'll do this as they come into my head now, rather than the way that Councillor Swift asked the questions. So if we look at the pay issue, and Scrutiny will know that I am a big supporter of the council seeking to try and achieve what is often described as the real living wage. We know that this year Cabinet agreed an additional investment to achieve the 921, which is above the national living wage increase. A similar role in the NHS might be a band 3, and that will probably be paid at around £11.14 an hour, so a significant difference. So whilst I have an ambition to achieve the real living wage, I think I'd be ecstatic if we could, either through regional work or through national work, get parity with Agenda for Change pay scales, because I think that would help. I think there is a role that we've got still to play, which is, I think pay is quite a key element to this. So people will feel secure if they feel that they're being paid for the skilled work that they are doing. And at the moment, we've got low pay but high skill, and we need to change that. I think there is a piece of work that we need to do, which is about creating a career pathway. And we've heard Isma's story about where she started off in her care journey and moving into management roles. We need to see that people have got some opportunities to really work through a career, as opposed to simply doing one role in care. That there's a wealth of things, and I've said this to Scrutiny before. My first role in social care at the age of 17 was to be a relief care assistant. I'm not suggesting that everybody would want to become a director of social services, but I think what we do need to do is to be able to offer people some real commitment and hope. I feel a bit embarrassed as well, I must say, because I think people have said some really nice things about the council tonight. And I think we have tried to work really hard in partnership with our providers and our care workers. But there will be examples where people have struggled. So we know that when staff levels have been low, staff have worked extra hours. You can't do that week in, week out, month in, month out. People need to respite. So we do need to tackle this issue about attracting people and retaining people in the sector. What we do as a way of, for example, in the home care field that Councillor Swift referred to, which is the bit about travel time, is the way in which we commission. Actually, travel time is built in, and it recognises that some care workers will be drivers and some will be on foot or use public transport. And we build into the hourly rate that we pay for an hour's home care travel time, so people are paid travel time, and we have what's described as an urban rate and a rural rate. The average across both those rates is £19. It's about £19 and 2p, which clearly needs to be improved in order that we can enhance the pay, but it is taken into account. I think that was all the questions that Councillor Swift asked.
I think that's enough to be ahead, Ian. Can I just say, I wasn't aware of the £19 and assumed that, well, some people actually got it added to their pay rates sort of thing, but it's good to hear it's different, and it can be looked at sometime with a different.
Excellent, thanks.
Sorry, Chair. I think just to be clear, when we commission, the hourly rate is on the average between urban and rural is £19 2p. The expectation as a minimum is that the worker will get £9.21. But clearly, if we were to achieve parity with the pay with the NHS sector, we'd be looking at the worker receiving £11.14p an hour.
Excellent, thank you, Ian. Councillor Hutchinson.
Thank you, Chair. I was going to say, despite Ian's blushes, that the compliments are on the partnership working between the providers and the support they've received from the council was very heartening to hear. But during for many months in the pandemic, care homes and hospitals were closed to friends and family visiting the residents or inpatients. And I've heard from very many hospital doctors how the impact of having to try and fill the absence of family support, how difficult they found it. And I'm fairly sure that that will have been felt also by staff in care homes. I was wondering what has been learned, have any lessons been learnt from those experiences to try and, if this were to happen again at some time sooner or later, and also whether the impact on staff has actually been recognised.
Thank you, Councillor Hutchinson. Ian, do you want to pick up on that?
I think Councillor Hutchinson has highlighted a really interesting point. I think as we entered lockdown, I think no one really knew how long we would be in lockdown for and what the impact on care homes in particular would be in terms of having to close its doors to regular visitors. Throughout the whole of the pandemic, there were some exceptions where visitors would be allowed into the care home, particularly if, for example, the relative was at end of life. I think all providers recognise that family, whether that be sisters, husbands, wives, sisters and daughters, the value of being able to keep that regular contact really does lift people's spirits, and it brings a real kind of energy to a care setting. But obviously at the very height of the pandemic, some of that contact had to be restricted. I think what we tried to do really early on is look at alternatives to, for example, some of the homes we supported to develop kind of standalone visiting areas, but using effective screening and PPE. Some of our residential homes were more adaptable because of the kind of layout of buildings, so it was easier, for example, where where there might be a lounge that had direct access with French windows from the garden. You could create a safer visiting area. We also supported homes to provide additional pod systems, that where if they had grounds or car parks. And during the summer, you would see people using marquee areas to kind of have outside visiting, but obviously that became more challenging with the weather conditions as they would change. I think we learned more about how we could do safer visiting and manage visiting throughout the pandemic. And so I think we've learned, I think we'll be better prepared, but that's not to say that when there would be outbreaks, actually you would need to kind of suspend visiting temporarily. But I think everybody recognises the vital role that family contact has made for people. And I think what we're also seeing, which I think is really positive, is that where families were saying that they'd seen deterioration in loved ones, actually getting back into that regular contact has brought people back into kind of feeling that there's a real big large life that they want to lead in the care setting. So I hope that explains some of that, Councillor Hutchinson.
Yeah, I was also interested on the impact on the staff, the emotional impact and whether that had been recognised. But could I also ask about whether we have a time frame for the development of a Calderdale provider workforce strategy, which is mentioned, and whether that is going to, how that's going to link with education and training providers, possibilities of outreach into schools, work experience opportunities and things like that. Are we, is the strategy going to be sort of exploring all of those options, and when might we see it?
So we're in the middle of developing that strategy now, and I hope that in the coming weeks we'll be able to kind of furnish Scrutiny with the kind of the time frame for its delivery. What you'll have heard in both what Michelle and Jules said at the beginning of their presentations is that we're not waiting for the strategy to be complete without engaging in some kind of activity. So, for example, Michelle referred to the pop-up approach to recruitment stalls in market towns and using the markets as a way of engaging with the public about the role of social care. So we will be developing it in a more rounded way. One of the things that we also know is that the ADAS, which is the Association of Directors, have a workforce network, and I have the pleasure of leading that for Yorkshire and Humber. So we're also going to feed into a Yorkshire and Humber wide strategy. But I think also as part of, we'll be talking a little bit later on tonight about the integrated care system. And one of the things I think I really value about being part of the West Yorkshire and Harrogate ICS is that they're taking the workforce issues of social care into account and see it as central, and it's not just a people strategy for health staff, but for health and social care. So I think you'll start to see quite a lot of activity, Councillor Hutchinson, and I'm more than happy to share the local strategy when it's ready.
Thank you, Ian. I'm going to bring Jill in because I think she may have something else to add to that as well.
Thank you, Chair. As Ian says, the strategy is in development, but what I can add is that we've already had quite a large engagement event with providers from care homes and domiciliary home care. We have three work strands in relation to this strategy. One of those currently is around raising the profile of social care, and we're working with providers for those testimonials from staff and from residents. And we have the council communications team and council human resources team engaged with providers in looking at how we can better promote social care, some of the things that Michelle Wright touched upon earlier. We have colleges and skills for care as part of our strategy group currently. One of the further work strands is that we're looking at once we have the material to do a proper campaign, Calderdale campaign, at how we can look at retention initiatives and possibly any sponsorships from local businesses to support that, to incentivize people to enter the profession. And then the third work stream is really around career progression pathways and looking at whether that be promotion opportunities, training opportunities. So the strategy is underway. It's just not a finished product, but activity is happening now. And we're linking into the National Department of Health campaign as well. Thank you.
Thank you. We'll look forward to receiving the strategy in due course. Councillor Barnes, you did have your hand up. Have you no longer? Right. Okay. I shall go to Councillor Parsons-Hulse.
Thank you, Chair. I'm sorry that I was late. I think Ian and Jill have probably answered my questions already. It was really around your recruitment and how we are going to get more people into the sector. I wanted to also ask Angel Wings, but I think I think they've left. Has that lady left now? I think she left. Yeah, I can't see her on the screen anywhere. I just wanted to ask if she'd been affected by losing members of staff due to the vaccine. Have we got any figures of people losing staff due to the vaccine?
Ian, do you want to answer that?
Yeah. I can actually supply. I can ask the direct question of Angel Wings. I think what will be interesting is, of course, is that it's not a mandatory requirement for someone working in domiciliary care to have the vaccine as yet, and it hasn't been consulted on. So Jennifer's business probably wouldn't be as affected by the implication of mandatory vaccines. But I think Isma kind of did talk about how that they have probably lost 2 really good care staff who, for whatever reason, have felt unable to consider taking the vaccine. In Calderdale, our overall number of people who work in residential or nursing homes that are CQ registered, the number of staff is quite a small number. When I look at some of the big cities, they've lost hundreds of staff through the mandatory vaccine. I think we're around, I think it's about, Jill, is it 40 or so, I think?
Yeah, that's it.
But those are 40 people who have got a breadth of experience who would have made and continue to make a good contribution. But I think what we have seen from the vaccination programme is it does help where staff are being vaccinated in terms of the kind of health and safety, and the risks to residents are that much more reduced.
Thank you, Ian.
Thank you, Chair.
Thank you. Councillor Benton, please.
Thank you, Chair. Probably a question for Michelle. It was mentioned in the report, and she mentioned it, about developing a staff bank. And I just wondered, is there any indication yet on how successful that's been in delivering more casual workers?
I can confirm that work is undergoing at the moment. This week, some interviews have actually started to be undertaken. So it's in its infancy at the moment, but the work has begun to start looking at that, yes.
And thank you for the message, Ms. Michelle. I think you're confirming that I've just lost the message now because someone said put something. Angel Wings haven't lost any staff due to vaccinations, and confirm that Valley View had lost 2 staff which they had been able to recruit for. So thank you for that message, Michelle. So over to Councillor Durrance, please.
Hi, yeah. I think you have answered this, Ian, but in the points that we need to consider, the bottom point says that we need to bring pay into line with the hospitality and retail sector. And you've obviously said different in the meeting, but it does concern me because the skill set levels and what they're expected to do isn't in comparison necessarily, is it? So that's, I mean, like I say, you have made reference to it, but
yeah. So I think what the report was trying to say is that we're with the current rates of pay, we are currently competing with retail and hospitality.
So I've misunderstood.
Yeah, so I think we're losing people. If I had a magic wand and a money tree at the bottom of the garden, I would be arguing that we should be paying 11.14, which is that equivalent to the NHS Agenda for Change grade for a band 3, which is kind of nursing auxiliary type role. And I see that as being where the parity is. But unfortunately, I don't have either the magic wand or the money tree, unfortunately. But it won't stop me campaigning for it.
Would you like to come back in on another question?
I think Ian's just answered my question. Thank you, Chair. It was just about what a band 3 NHS role was, and it's just answered that. Thank you.
Okay, so thank you very much indeed for that. Nobody else is indicating to speak, so it's a real big, massive thanks to Michelle, Isma, and Jennifer for attending this evening and giving us a real insight. This is what Scrutiny is all about, actually finding out what it's like on the ground level. Rather than just receiving a paper. And the paper is very useful, of course. Councillor Swift, you want to add something?
Yeah, just we've talked an awful lot in that round about pay, etc., which, you know, we all agree with what's been said. And a lot of people need it desperately for when they, you know, home to help with what happened. But some of these people, most of these people, feel very strongly about what they do, and they're not there necessarily because of pay. And I didn't want it to come out wrong when, you know, it was written up. Is that all right, Chair?
Yeah, absolutely spot on. The last thing we want to do is upset Michelle or the rest of the team. So I'm sure she won't go away upset, and I'm sure Diane will reflect that in the minutes as well, to give our formal thanks to all the frontline staff who work extremely hard above and beyond in so many different cases. So very much welcome your input this evening, and of course we look forward to receiving the strategy in due course at a future meeting, Jill. So we very much would love you to come back. Ian, would you like to add anything to that, please?
So I was attempting to be really clever and geeky by putting clapping hands, but they don't appear to be clapping.
Probably not, actually. No, actually, they probably were, but I recognise them as just someone put their hand up. When you're chairing a meeting, when your yellow hand goes up, you just see it. So yeah, you did. Thank you ever so much for that. So that concludes item number 5. Michelle, you're more than welcome to stay, of course, but I'm sure you have more pressing things indeed. And likewise, Smith, and thank you for attending. And we'll now go on to item number 6, which is Calderdale Cares Partnership Agreement. Rachel, I believe you're presenting this. Do you have anything to add to the report that's in front of us?
Yes, thank you, Chair. I'll just give a bit of a verbal overview to help set the scene a little bit, if that's okay. So you'll remember that we came to the Scrutiny Board back in September as part of the Scrutiny Day session about the Health and Care Bill and what the implications for integrated care systems were going to be from April, and then in turn what that was meaning for Calderdale. So at that point I spoke around what we were doing to help continue bringing health and care organisations together in Calderdale under the banner of the Calderdale Cares Partnership. So one of the pieces of work that's come out of this programme is around developing a partnership agreement, which you might think, what on earth actually is a partnership agreement? So they come in all different shapes and sizes, called a manner of different things depending on the place that you're in. So we're calling it a partnership agreement. Other places might call it a memorandum of understanding, a collaborative agreement, a strategic partnering agreement, lots of different names. But essentially what they aim to do is set out how the partners that are listed are committing to work together. So it'll include things like what the vision is, what the objectives are, values, principles, that sort of thing, and then potentially around a governance framework as well. So over the last couple of months in Calderdale, representatives from our different organisations have helped to draft this agreement, and that's what's been shared with the papers today. Now, in saying that they come in all shapes and sizes, what they actually mean in terms of how they can be implemented are different as well. So some partnership agreements might be completely legally binding, some might have bits that are legally binding, others may not have any legal implications whatsoever. And in Calderdale, we're taking that last approach. So we've written something that we're saying it's not legally binding on the different parties. This is about, you know, good faith collaboration based on those partnership principles. Similarly, it's not adding in any contractual obligations to the different parties. Everyone will retain their own responsibilities and their statutory responsibilities as part of signing up. But this is really about saying, this is what we want the Calderdale Health and Care System to be known for. This is how we want to work together, and this is how we're going to get things done. Whilst we said that we don't want it to be legally binding, we definitely do still want it to be something taken seriously, something that organisations do properly sign up to. So ultimately, the position that we want to get to is by the end of February next year, so ahead of some of the formal changes coming in April, we want the different partners that are signing up to this agreement at this stage to take it through their formal boards, their cabinet, their governing body to say, yes, we are formally endorsing this, we are signing up and saying this is how we want to work together. So in the lead up to that, over this month and the start of December, we're taking the draft round different organisations' governance to help sort of warm up the system a little bit, give people an opportunity to comment, people who've been a bit less involved in the development to give some feedback and be sure of what they're signing up to when the formal draft comes back in January and February. So that's where we've got up to at the moment. Much like the way the partnership as a whole will keep developing, this is, you know, it's not going to be a stagnant document. There are bits of this that we're still working on at the moment, so the governance model in particular. We spoke about that a little bit at the last meeting. And similarly, as the partnership carries on maturing, there might be things that we want to build in at a later point. So we're saying at the moment, this is how we want to work together, but actually recognising that that document should be updated as the partnership matures and develops as well. So we thought it might be of interest to members here today. So sharing the draft document for information and to receive any comments on that. Thank you.
Thank you, Rachel, and thank you for giving us an overview of the documents. I think it is really helpful for documents like this to come to scrutiny, so members have the opportunity to point any issues. So I'm going to start off with Councillor Barnes. So Councillor Barnes, first of all.
Thank you, Chair. I don't like this document. Let's be clear and let's be upfront. I think it's woolly. I think it's vague. I don't think it defines sufficient. There's no sufficient definition. Might be more accurate. And a prime example is in relation to, let's say, I've lost it now, but you know, the duration. This will continue in full effect until such time the partners agree that alternative arrangements would better serve the needs of the partnership. Well, I'd like to go around this room and identify anybody who can understand that, anybody who can actually tell me what it means. And I bet you each of us will have different answers to that. And you've got a number of partners involved in this, all of which could take different views on this. I think also, without seeing the Constitution document from higher up the tree, I think it's very difficult to look at this partnership agreement in relation to that and how it works with that and how it dovetails into that. So please don't take this as anything other than it's just a document I do not like. It's full of motherhood statements. It's full of nice woolly. This is what we'd like to achieve. Very little to scrutinise on. Very little objectiveness. A lot of subjective around there, which is very difficult to scrutinise and come back at a later point and look at and say, this worked, this didn't work, this needs to be changed. So I have to say that's my overall comment about it. Thank you, Chair.
Thank you, Councillor Barnes. Rachel, do you have anything to give back on that? I know you said it's not a legally binding document, so what impact does it really have, I guess?
Yes, I know. Thank you for those comments. It's good to hear your feedback. So I'd say you're right that it is, you know, it is a subjective thing. There are it contains what people might see as sort of the fluffier side of things, but actually this is about taking that next step as a group of organisations together to say these are the ways in which we want to work together. Now, this isn't to, please don't get me wrong, this is not a document aiming to set out you know, the full priorities of the partnership, exactly how every single thing is going to work. So in that sense, there's not going to be perhaps all of the detail that you'd want to see at this stage. And again, some of that is because we're working through it at the minute, and some of those other things actually I think we're better placed in different documents rather than in this. In terms of the work around the Constitution, the only thing I would note at this point on that is that, and we've had discussions across the full integrated care system about this, but to be clear, this is something that is particular to Calderdale as a place, rather than to the Integrated Care Board. Whilst the Integrated Care Board will be a partner going forward, this is about the Calderdale as a full place. So we have had discussions around where it might be helpful to include some consistent language about the role of the Integrated Care Board or the link into that. But again, as that's all developing at the moment, that's not something we've been able to include at this stage. Yeah, I think that covered the points.
Can I just come back on a couple of points there, Chair? One, why did we decide not to make it a legally binding document? And secondly, you mentioned that there are other documents which relate to this, that might be in this or that they've been put in other documents. It's therefore very difficult to see this document in isolation. And that was my point in regard to the Constitution, is you're looking at a document in isolation when, from what you're saying here, there are other documents around it. So it's very difficult for us to make an assessment on this document when there are 3 or 4 or 5, I don't know how many, other documents sitting around it. So firstly, why did we not go legally binding? And I think the second point just confirms my concerns about this document as a single document.
Rachel, would you like to come back on that at all?
I'll just ask Neil, did you just want to come in? I'm very happy to come back afterwards. Thank you.
Thank you, Rachel. Yeah.
Okay, thank you, Rachel. Thank you, Chair. Mike, so there are legal complexities about why this isn't a legal document, and some of this is about how local authorities in the NHS work. So it isn't legally able for local authorities and the NHS to have a legally binding document. The Constitution is actually out for consultation and engagement. It has been shared with all local authority leads and scrutiny officers, and I think Bill will be discussed at the West Yorkshire Scrutiny Committee in the next coming weeks. So that is out for consultation. I think we brought this here today following on from previous discussions around it. We can take those comments back. The document will be approved by Cabinet for the local authority, and I'm sure it can take feedback from yourselves as a scrutiny committee about what needs to be included. With regards to sort of the overall outcomes that you mentioned earlier, they're within the Calderdale Cares Health and Wellbeing Strategy, which is set through the Health and Wellbeing Board. That's what the committee will be held account to for delivering going forward. So there are a number of documents that you're probably right, haven't been put here together, but we were asked to sort of bring the partnership agreement as part of an update of an ongoing process. So I do apologise, you've not got everything in front of you, but everything is being shared and is being open and transparent in this process.
Thank you, Neil, for the explanation. I think you've saved Ian Baines from having to come back in on anything on that. So thank you for the explanation. So move on to Councillor Hutchinson, please.
Thank you, Chair. I'm not a great fan of either this document or organograms in general, but I did wonder how the responsibilities for deciding strategy are divided between the Integrated Care Partnership, the Health and Wellbeing Board, and Calderdale Cares Partnership Board. I also wondered, if there's a resident in Skirkett Ward who is developing problems of confusion and memory loss and unable to, and there's concerns about their ability to continue to look after themselves, what will Calderdale Cares change? What difference will they notice, the people that care for them notice, for the fact that Calderdale Cares exists?
Thank you, Councillor Hutchinson. Who would like to take that one? Oh, Neil. Thank you, Neil.
I think that's a valid question, Colin. I'm not sure that's for Rachel and I to sort of answer today, because that's around the Health and Wellbeing Strategy and the Health and Wellbeing Board and its members, which I'm sure quite happy to look at the outcomes and for other members of the group to come and present to scrutiny on that impact. But that isn't the purpose of what's being presented today, Colin.
Right, okay. Then my other issue is it's quite a complex arrangement, this. I mean, I can't quite see where primary care networks actually link in with Calderdale Cares. But when we're scrutinising services, what goes well and what goes so we can learn from it, and what goes badly, where will responsibility lie? Who should we be actually calling to give evidence? Who should we be inviting to actually scrutinise these services? Because it doesn't seem as if anyone is taking particular responsibility, as far as I can detect.
Ian, do you want to come in on that, Ian Baines?
I think Councillor Hutchinson raises some really important points, and I think I'd want to reassure Councillor Hutchinson in particular that the PCNs are very much part of Calderdale Cares. I think the difference that the resident hopefully will experience when it works well is that there will be a team around that person, and it may not be obvious who directly employs that team, but they'll deliver seamless care at the points where support is needed. And I think particularly with the example around dementia, is a team that is supportive to help them understand the likely journey they are going to go on as an individual and as a family, but also one that can adapt and be flexible at the points where the dementia may be progressing and they need some further support. I think the bit about holding to account is that there will be an integrated place partnership that will be responsible for setting the parameters of how we will work and to deliver integrated care. And actually, we'll still have the opportunity, as scrutiny, you'll still have the opportunity to call in either a director of the PCN or the community provider through CHFT or my own directorate. So some of that ability to scrutinise what individuals are delivering will still be there. But hopefully what you'll also have is the ability to understand collectively what we are delivering as a partnership to deliver good health and social care. So I hope it would enhance your ability to scrutinise rather than dilute it.
Thanks, Ian. Neil, do you want to come back on that as Neil Smith, please?
Yeah, thanks, Chair. Sorry, it is complex, Colin, and structures aren't yet finalised for how the integrated commissioning board and local sort of partnerships will work. But we are envisaging that for things like general practice, as you sort of alluded to there, we will still have local commissioning-based teams who will be able to be called to represent, and we will still have our 21 general practices, LMC and PCN clinical directors as provider of those services that can be called and held accountable as well. So we do think we'll be able to build on the mechanisms that we've got in place with CCGs and current relationships. It's just, it is a bit grey about structures. CCG staff have yet to be transferred to the ICB, and those structures are still to be confirmed. We are expecting local place arrangement to be in place, but you may be aware Rob Webster was only appointed as the chair designate for the ICB last week. So there's quite a lot to do with regards to staffing and local commissioning arrangements to ensure that we've got those in place for the 1st of April. But in essence, hopefully locally from a commissioning and an NHS services, not a lot will change, and we'll continue with the relationships that Ian has with Debbie and myself and Debbie Robinson and the work that we do across the system.
Thank you, Neil. As you've rightly said, I think things are evolving extremely quickly, and we need to be updated as soon as that information comes to hand. So, Councillor Kingston, first of all.
Just again, my first thought about it not being legally binding is kind of like, what's the point? How is this going to have any impact if there's no way to make anybody in it accountable other than through scrutiny? that's just a general thought. I've got some very specific thoughts on the agreement, which relate again to my pet hate, the English, the quality of the written word in the document, which I think is in places very poor. Particularly, I want to know, is this cover page that we've got in our documents that we've been provided, is the cover page going to be provided with it? Because if so, it very badly needs revising. There's a paragraph near the bottom. The Calderdale Care Partnership is rooted in local knowledge, shifts in power, distributed leadership, and most importantly, its innate values and behaviours of kindness and resilience. What's innate values? There's a lot of mixing up of subject and object in this sentence so that the meaning is completely obscured. I think it's the beginning of the next sentence is particularly ridiculous. As a place, Calderdale has strong relationships across its partnership and with its people. How do places have relationships? That's absolutely utterly ridiculous. And then continually seek, how does a place continually seek to listen and to learn from communities? That absolutely totally needs revising. That's specifically the English. And then my other thought was just later on, page 31 in our documents, the partnership's vision, objectives, principles, values and behaviours. Says, our vision for Calderdale is for a place where you can realise your potential, whoever you are, whether your voice has been heard or unheard in the past. I just wonder, that final point, whether your voice has been heard or unheard in the past, why on earth is that in there? It's entirely unnecessary. Cut that out.
Thank you, Councillor Kingston. That's extremely useful. Can I potentially suggest that we set up a meeting with, would it be Rachel that goes through this information? Because I think it's key elements that you picked out there. Rachel, is it something that you'd be willing to set up so that you can go through details, so it is a better document, I think, in some ways?
Yes, please may I also just come back on a couple of those points as well?
Of course you can, yeah.
Just for clarification. So very happy to take on those comments, thank you, and it's useful to hear the feedback. In terms of the cover paper, that is different for each different place it's going to. So broadly, the main messages are the same, but we're clearly tailoring it to the organisations it's going to. And apologies if it hasn't landed quite right for this particular audience. The bit that I would just come back on the vision. So where the vision has come from is actually the work that was set out a few years ago through the Council on Vision 2024. So that is the same wording that's taken from there, and actually we had quite a debate around that being a vision that the different partners had already signed up to. So do we actually say, whilst it might not come across specifically as a health and care based vision, actually those core principles around things like a place to live a larger life, if we've got good health and care, ultimately those wider determinants of health and care, they're going to come into that. And so we debated whether or not should we be thinking about a different vision specifically for the Calderdale Cares Partnership, but actually felt that, this felt right, and it felt like something that people had already signed up to. It sort of resonated with people. So completely accept the wording on that, but we have kept that the same as the original document from a few years back.
Thank you for that. So Councillor Swift.
Thank you, Chair. Just a quickie, we're talking about care and care homes as though it's all one. It can't be all one, because different people want different things. And just going back for a minute to care homes, some specialise in different things. And how does I ain't got a mum anymore, so I'll use me. How would I, if I want to care for my mum, pick from how they do? Where's the necessary help with, what do people specialise in? Oh, if it's dementia, I can see that. But there's other bits and pieces that it must be very difficult.
Thank you, Councillor Swift. Would anyone like to add anything to that? I'm looking around the room. No, Councillor Barnes in that case, please.
Chair, thank you. Thank you for allowing me to come back. It wasn't meant to be, nor is it meant to be a criticism of individuals, but I'm starting to get some concerns here that we're 4 months out and none of the arrangements have been organised. We're hearing a lot of we hope, we think, we believe, we feel. There's nothing concrete, and I appreciate this is, as I said, this is not a criticism of the individuals. I'm just getting concerned that we're 4 or 5 months out from what is a major change. Things are changing almost daily. We're hoping that it will improve accountability and scrutiny, but we can't put a hat on that yet. We don't know who's coming in and things like this. I am really getting some serious concerns here that we as a local authority and we as elected members are going to be sidelined and not allow us to do our job post April. And I think, Chair, I think you said the right thing, is that it needs to come back, keep coming back to us as soon as possible with things that are happening for us to have our say and have our thoughts on this. And as I said, it's not a criticism of the individuals. I appreciate the circumstances have been placed on them, but we really need to be on top of this. Otherwise, our residents, the residents of Calderdale, could be at a disadvantage. And that's what we're here for.
Thank you, Councillor Barnes. I think my closing remarks will conclude with some things that certainly will incorporate your concerns there. Councillor Hutchinson, welcome back.
Thank you for giving me one last crack. At the moment, if the scrutiny, we're wanting to discuss the design of services that are produced, we can go to the CCG to ask them. Who will be the commissioner that replaces the CCG with whom we can discuss the future design of NHS services?
Thank you, Councillor Hutchinson. And luckily, I was pleased Neil's put his hand up to answer that. So Neil, please.
Thank you, Chair. So Colin, the CCGs, the 5 CCGs across West Yorkshire will be merged into the West Yorkshire Integrated Care Board. That will have responsibility, and then it will hopefully delegate those commissioning responsibilities down to the 5 individual places. So that's what Rachel sort of is being presented today, is the local arrangements and what Ian's leading on with regards to the setup of our local sort of integrated commissioning sort of partnership, our Calderdale Cares partnership. So we will have local commissioning staff such as myself and Debbie still hopefully within the locality, and we will be our main points of contact for local authorities and for scrutiny to help develop services going forward. So hopefully the faces won't change, it will just be the names on the bottom of our name tags, and hopefully we'll be able to confirm that as soon as possible over the next few weeks. On your point, Councillor Barnes, around we're fast approaching April. We are. The legislation hasn't even been passed yet. That's one of the difficulties. So we're doing everything as quickly as we can, and hopefully there'll be minimal disruption to be able to continue the good working relationship we have with yourselves and with with Ian and other partners on everything we do.
Thank you, Neil. Thank you for those comments. Nobody else is indicating to speak. So I think whilst we welcome you, our involvement in producing this document, we have great reservations as it stands and its usefulness as a document, and therefore really do request that we are kept up to date as soon as we have the additional information that will give us a clearer position as to how our involvement as scrutiny can continue with the different bodies and organisations, of course. So I think that's what I would say if members are in agreement with that. But say very much welcome the report. Please don't go away upset, because we are your critical friends as always. We like to make it. We want to produce a document that is actually of some use and significance. So thank you, Rachel, for presenting that, and thank you, Neil, for some explanations behind some of the more complex things that we're not quite fully aware of. So we'll close that particular item, and we now go on to item number 7, delivering Calderdale Cares, developing our community services. So welcome, Debbie Graham, just in case you've forgotten your last name again.
I think there's a presentation that I think Pisana's going to put up, and I think Neil's going to kick us off. There are a few of us here tonight. Sean, you'll know from the local authority, Michael from CHFT, Rona, and myself and Neil from the CCG. Sorry, I was filling a form in with my maiden name on it before I came in, and it just... You don't know where these things come from. You really don't.
Absolutely. Welcome on board, all of you, to report this. So I'll let you go on with the presentation.
Thanks, Chair. Thanks, Debbie. So I just wanted to give a bit of an overview in the context of the detailed report that you've been provided today. So this follows on from the ongoing discussions with the Joint Overdue Health and Overdue Scrutiny Committee with Kirklees about the right care, right time, right place hospital reconfiguration plans. And to remind sort of people that there was a Secretary of State referral for the reconfiguration, which came back with 3 points too, which are heavily linked. And the reason we're doing the work and providing the detailed information in the report. And one was around the reduction in beds, which was a concern for the Secretary of State. And those beds are now back in the model. They are maintaining at the levels we have. And the third point was about ensuring community services were sufficient for the level of beds. And part of that has sort of been surpassed by the fact that we're not taking beds out. However, I think we recognise that community services is a priority for both Kirklees and Calderdale. And the Scrutiny Committee were aware of a report that we commissioned through McKinsey's about what future models of community services should be like going forward. So we've put a detailed report together, which we referred to at the Joint Committee, which we said we'd take through our local place-based committees. So hopefully you've had a chance to sort of read all the detailed information in there, which addresses the 13 points made by McKinsey's and how they're being addressed. And just part of the presentation today is all the partners to recognise all the work that goes on in community services. One of the things I will point out, though, is that there is not a detailed spreadsheet modelling of capacity for community services that can be tied into bed numbers or hospital activity. Unfortunately, that sophistication doesn't sort of exist. However, we've got a lot of information that we've tried to answer as many questions that have been raised in the past in the report. So I just wanted to give that overview and the link to the joint scrutiny and the referral to Secretary of State. And I'll sort of hand over to my colleagues around the work that we're doing. So Rona.
Thanks, Neil. So I'm going to start with the partnership and just explain a little bit about the partnership, remind people who's involved in this work. So the following partners on this slide, as you can see, are the partners, the 8 partners that signed up collaboratively to deliver seamless community services, and that's both physical and emotional health services. The 8 partners are Calderdale and Huddersfield Foundation Trust, ourselves as a clinical commissioning group, Calderdale Metropolitan Council, all 5 primary care networks, Locala Health and Wellbeing, South West Yorkshire Partnership Foundation Trust, the voluntary and community sector, and West Yorkshire Pharmacy. And we work together and meet monthly in order to deliver that seamless community services. And throughout this presentation, hopefully you'll get a bit of a flavour of some of the things that we've been doing as we've been working together. So if we move to the next slide, thank you. So just thought, using some of the feedback that we've received since Care Close to Home and the Right Care, Right Time from people, and the key themes from people have been around wanting a timely response from a single point of access. So people have kept telling us we only want to tell us their story once, and we're working really hard on ensuring that people are able to, there's less handoffs from people and people are being managed collectively. Coordinated and personalised care plans and coordinated care is another key theme. Services closer to home has for some time been one of the important factors that people have said that they want to see more of, especially in some cohorts where we have people on low incomes, older people age 65 plus, people with impairments, people with long-term conditions, and parents So that was another key factor that came out from the consultation and engagement work we've done, and receiving the right care in the right place at the right time. And people want to spend as little time as possible in a hospital bed. And you can see on this slide some of the quotes that came out of that consultation, and that was included in the care close to home specification. Next slide. I'll hand over to Debbie.
Okay, so Debs Harkins unfortunately has another meeting tonight, but she would have just shared these two slides. So I think we had a discussion earlier on in the last section just about what is it that Calderdale Cares is all about, really. And so this is a very short summary, but that better wellbeing for all, that whole notion about harnessing the strengths of communities and the work with the voluntary sector. The seamless services, so this is the element of Calderdale Cares that we're really focusing on tonight, which is about how we collaborate, as Rona's just talked about, and then the whole working together bit, which I guess links back to the conversation we had about our local partnership arrangements and through that network. So that staff actually, regardless of where staff work, they're there providing services for people in Calderdale. So basically, in terms of strategic direction, that is Calderdale Cares. It's where we go back to each time. If you want to go on to the next slide, this is the one again that Debs would have presented, but I think the bottom line for this is that Deb's vision, our vision, is in this triangle, really, and it won't be something that people haven't seen before, but and that bottom segment, keeping people well, going up to preventing illness, and finally at the top, preventing admissions to hospital and loss of independence. I think it's fair to say that when we look at investment and work that we've done over the years, we spent a lot of time possibly in the top end of that triangle, and our aim as we work through this work is actually to do much more about prevention of admission, and much more on keeping people safe and well, and those wider determinants that we discussed earlier on. So I'll go on. So I'm going to just bring Michael in from CHFT to just talk about, so that's a strategic direction, and this is the kind of very high level model that we are developing. So I'll hand to Michael.
Thank you, Debbie. So I won't go through each of these bubbles in turn, but I'll just talk about the principles which allude to what we've talked about from a partnership perspective and what we touched upon in terms of some of the PCN-based and hub-based working. So I mean, the key themes of this is really that the individual is centred to whatever we were doing. So essentially what we're trying to do is design and configure our services around the individual needs and try and make sure that's a multiple agency. So council, community healthcare, community mental health, voluntary sector, working together across those teams. I mean, the key bit then is about, on the PCN and the neighbourhood base, is trying to make sure that when we talk about care close to home, we genuinely mean it. So we have some very practical examples of where services which were historically delivered in the hospital, like physiotherapy, we are explicitly aligning those physiotherapy services with the GP practices and the PCNs, so that if you want to access those services, you can do them much closer to home. And we're delivering many, many more services. So we kind of touch upon district nursing, but the wider nursing, therapy, voluntary sector, social care staff working in those hubs and working together is a key part of this. Deb's touched upon the vision from Deb's Harkin in terms of that living well and that preventative agenda. So really what we're trying to do as well, and we'll come on to this in some of the following slides, is making sure our activities not just focus on reacting to problems when they arise, but how when we work with GP practices and the information that's available to GP practices and partners, how we identify need early. And that's much easier to do when you're working at that neighbourhood level compared to when you're working within a hospital. The other key bit of then is that I think if you're a GP or you're a paramedic or you're a patient or a service user or a relative or a carer, trying to access these services can be extremely difficult. So quite often they have their own access referral points for telephone numbers, email addresses. So one of the key enablers for this is trying to make sure we have single points of access. So around that circle, you'll see that there are a number of single points of contact, which even though you can see 3 on your diagram there, that's a lot less than we currently have. So trying to make sure that access is easy for individuals, carers and GPs is critical to this. We'll just move on to the next slide. And then we'll give some practical examples around how we're doing that in action. So again, we've talked about the kind of alliance agreements and what does it mean in practice. And we'll be able to describe some very practical examples about how we are working together across agencies and delivering some of those ambitions in that triangle. So if we just move on to the next slide. So I'm just going to touch on anticipatory care. So this is really when Debbie talks about that bottom of that triangle, this is really about identifying needs early and trying to avoid people becoming unwell and trying to support people to live well. Now, that top right-hand box there is critical to this. So between general practice, between secondary care, between the local authorities, we have enough information in those systems to help guide individual decision makings for individual patients, service users, citizens, but also how we configure our systems. And that's really critical to enabling that anticipatory care and that shift from reactive to preventative care. And we have enough in there to tell us, so if we take frailty and older people as a good example, within our GP systems, we have a thing called the Electronic Frailty Index. Now, beyond the technology of that index can tell us what the needs of the individual are. So we know if they're on lots of medications, we know if they've got dementia or delirium, we know what their comorbidities are, we know what some of their social needs are. If we use that information in an effective way, we can then deliver services against those needs. So rather than the patient turning up in A&E or in our local same-day emergency care, we have that information, we can identify those needs, we can develop a personalised plan of care according to those needs and develop a preventative care plan, but also reactive care plan. So if they do go into a crisis situation, they don't have to repeat themselves. The carers don't have to repeat themselves. We've got a plan in place that in individuals, whether you're a paramedic working for the Yorkshire Ambulance Service or you're a frailty nurse in the ED department at Calderdale Huddersfield, you have a plan that can be responded to. It's also about the individual. So if we just go back to one, back up again. It's also not about us doing to people, it's encouraging people, patients, citizens, carers, family members to make informed choices around their lifestyle. So there's a lot that we can do in terms of making sure that when we do see patients in the community, we're not just treating them as patients, but we're treating them as individuals and making sure that, as Rona alluded to before, that we don't just concentrate on their health needs, but we look on health, physical health, mental health, social care needs. That holistic biopsychosocial model is critical to this. Okay, we just come to the next slide. I think this is handing over to Rona.
Thanks, Michael. Yes, so enhanced health in care homes, and we've touched on this earlier in the conversation that you had in Scrutiny around care homes and the care home support during the pandemic. And the enhanced health in care homes service is a service that was set up just pre-COVID and was key to part of the support that was provided for care homes. In essence, the model is about moving away from traditional reactive models of care towards a proactive care that's centred on the needs of the individual residents, their families and care home staff. And it can only be achieved really through a whole system collaborative approach. So it's been very clear with the enhanced health in care homes, and I know we've already described this previously to Scrutiny, so I won't labour on this slide. It's a key factor of being able to support care homes and being able to ensure that people are supported as early as possible, that care plans are delivered and developed through regular reviews with the person and on their carers, and that it's very much around a proactive and collaborative approach. And the next slide gives you a bit of feedback on from both, it says from care homes, but it was also through feedback that the care coordinators in the primary care networks received from adult health and social care staff as well, about the really fantastic support that they've provided. So enhanced care homes is delivered by primary care networks, and they've included some additional staff to support care homes and support the system at that very early stage. And the feedback that you've got in front of you is feedback to the care coordinators. So the system is saying very much, care homes are saying how much support that they've received from the service. They've been able to get quick access to GPs because they can use the care coordinators to access them and access the GPs without going through the surgery. It's developed and maintained some really crucial relationships between GP surgeries and care homes and wider system staff. It's very much been part of the crucial element of the pandemic. And the final one talks about how fantastic that they feel the services and the link between social and health and the improvement it's made for them. I'll move on to the next slide and hand over to Sean.
Can I just ask how many more slides there are? Because we just need, I'm just conscious of members needing to ask questions as well. So it's just really going through as quickly as.
There's just three more slides.
That's fine. No worries. That's fine.
Three more slides. Thank you, Chair. And I'll go through this really quickly. So this is really the in terms of what Michael, Rona, and Debbie have just outlined. This is the operational encapsulation really of the way that we're working. So operationally, the urgent community response service that will be implemented in December of this year, so next month, is about a wraparound service, particularly for people or focused on people who are at high risk of being admitted into hospital. So it's a wraparound service with different disciplines such as advanced clinical practitioners, independent living officers that used to be reablement officers, with a whole set of skills, and there'll be therapists involved and nurses too, to support people who are in crisis. And rather than go into hospital within 2 days, within 2 hours, there'll be a response. And within 2 days, more services will go in so that over a 7-day period, they can be supported to remain at home and reduce that level of crisis. There will also be other services that are linked into this. So behind all of this, there is a system that we've tried to simplify to ensure that there's easy access for predominantly or primarily GPs who will be kind of contacting this service for people who will need it. So there will be closed systems with YAS, and also there will be a service in place to make sure that the single point of contact is quick to use. Can you go to the next slide? I think it's Debbie's, and then the final slide.
Okay, I'll do this really quickly. So there is quite a lot in the report that members have had about what we think in terms of the impact some of the services that we have in place already have made. The report just gives a context, which is very much a higher level of population that then was predicted in the McKinsey report, and it's in the context of that this is written. So although we've seen an increase in actually unplanned admissions themselves, we've seen a reduction in bed days, which is really what's critical for the acute trust, and you can see the reductions on there. And they aggregate, so it's 0.3 days per patient, but when you aggregate that up overall, and particularly for our older age groups, that is significant. We've also included some information about some other indicators. One talks about the length of stay. So we're measured nationally on length of stay over 14 and 21 days. And you can see that we're doing well in terms of comparison with both. Rehabilitation, we've booked the trend really in terms of increasing the numbers of patients that are still at home after 91 days of discharged into rehabilitation services. The older people remitted to hospital, our national rate is in line with our commitment to home first rather than admission. And patients, I can't see the last one actually because there's a thing just gone up, sorry. I can't get rid of that. Or proportion of patients discharged from hospital to their their residents. So we just put together a few of the indicators that we thought would be helpful to show. And then on to the last one, if it just makes it easier, I'll just finish this off. So where are we going next? We've learned a lot from the pandemic. Up to now, we've focused particularly on supporting our acute sector, and we'll continue to do that. But actually going forward, we are looking to move towards the bottom of the triangle, working in localities, supporting people, in fact, identifying rising risk through the work that we've talked about, and ensuring that our resources are targeted to enable us to do that, and using a wellbeing strategy outcomes as a way of measurement. So I think that is it. So we could take those slides down now.
Thank you, Debbie, and thank you for the team for presenting that. So that's most useful. Right, okay, your hands have appeared. So in no particular order, I will take Councillor Kingston first.
Thank you. I just had the thought when I was listening to all that this really doesn't match my experience of attempting to get support things put in place for one of my constituents, an elderly lady that's clearly developing dementia. I've had to fight really hard and chase people constantly to get anything put in place for her. Basically, without that support, she'd be falling through the net, and I hate to think what condition she'd be in now if she'd not had somebody chasing. And that shouldn't have to be the way it is, for I imagine that that's how it is for family members as well, that are attempting to get things put in place for their elderly relatives. So I've not, although it sounds lovely reading the report and listening to that slight, presentation, it all sounds great. I think that what we're being told doesn't match the reality of what people are actually experiencing in Calderdale. That's my experience. It doesn't match the reality of my experience in Calderdale of this seamless care system that we're being told about. And then I wonder if there's, I had one question about the increased admissions. Although it's great that we've reduced the length of stay, the increased rate of admissions that's being reported, does that mean that our population is getting sicker? Are our prevention strategies at the bottom of the triangle that you showed to us, are they really not working? Thank you.
Thank you, Councillor Kingston. Who would like to come back in on that? Oh, yes, thank you, Debbie. Thank you for that.
Yeah, I think numbers have gone up, so we've seen an increase in the rate, but we've seen a significant increase in the population as well. So that rate, although, and obviously there's a relationship between the two. I think your description of people finding it hard to navigate services is exactly as Michael said. We have too many access points, and we believe that, albeit there's still are 3, that's probably reduced by 10 at least. So I think we've a lot to do in terms of that. Are our population sicker? I think our aim is to move down that prevention triangle. I think we spend a lot of time, rightly so, trying to stop people from getting sick, but actually we need to really attend to that bottom triangle where we're looking at the wider determinants of health. And I think hopefully in the report that we wrote, we talked about a lot of things that we've done, but under every one of the sections was, what do we plan to do next? So we're not complacent about our system not being perfect. And as you say, Councillor Kingston, our aim is to continue that. And I think some of the things that we've shared tonight are about our ambitions to move forward.
Yeah, I just want to come back that it wasn't just my experience of the initial contact, it was the experience of what was done following the initial contact, that it wasn't great, that it was dropped quickly, that they weren't following up, there wasn't enough investigation into what was going on. I felt that this lady was being abandoned, basically.
Thank you, Councillor Kingston. Michael, do you want to come back in on those points?
I think the good observation, I agree with everything that Debbie has said. I think there is something in terms of the admissions. I think we are seeing patients and people attending who are got higher levels of acuity and complexity, so they are presenting with more complex conditions. And I think there are some pandemic impacts of that in terms of deconditioning, particularly across that wider and older population. So there's no doubt about that. I think that's absolutely an observation that we will see across the system. So we read a hospital, social care, we're definitely seeing that. I think your point about the disjointed of services in terms of accessing them, and then once you've accessed them, how do you move through the pathways? I think they're absolute observation, and we would probably, if we're being honest with ourselves, we'd say that's absolutely some of the issues that we've got. I think what we're alluding to is we're giving you some really good examples of areas where we're addressing that. It's not the totality of it, but hopefully by describing that vision of that, what we've got and that triangle, as Debbie alludes to, hopefully then we will work in a more integrated way, and we will try and nip problems in the bud rather than dealing when they get to crisis. So I think they're good observations, but there's certainly much more to do.
Thank you, Michael. Councillor Swift, you did put your hand up for the presentation, so I did notice you. Then you took it down. So if you'd like to come back in, Councillor Swift.
I very much support what Councillor Kingston said, and I know Neil will tell me my idea of community group services isn't right, but we've been being promised this, and it's not just the NHS or the council, it's all the partners to one. We've hardly got, it sounds really good when you hear it put together, but when you have a very elderly gentleman who has been in a hospital, is sent home with no plan or anything, fell out of bed in the middle of the night, he'd been sent home, and he was only seen when somebody called in later. Then he had an awful long wait for an ambulance. But I am not blaming the staff for any of that. But, I sometimes wonder if we're working on, let's keep it as, well, I don't know what I think we're working on. And the point about increased numbers, I'd like to hear what somebody has to say. If these increased numbers, or a section of them, are in ambulances going to A&E because they can't get an appointment with the GP.
Thank you, Councillor Swift. Would anyone like to respond to that? Just looking, so I can't find anybody. Right, okay, can I come to Councillor Barnes?
Thank you, Chair. I think I'm in danger of becoming the Norman Hunter of this of the Scrutiny Committee. First of all, thank you for the comprehensive details, and actually at times very difficult to digest and read document. I did find it very difficult to go through as a document. That might be me. However, just picking up some points. Page 45, the table needs correcting because the figures are wrong, or there are figures on my chart which don't seem to have anything associated with it. Your running costs say net change over 3 years, 180,000, meaning an increase, but it actually decreased by 180,000. Some of the figures are in red, don't know why, some of them aren't. So I think that chart, that document, that table, which is quite a critical table, does need correcting. And there's a line of figures, 4 figures, which don't just appear from nowhere. One of which was, and as they're all in a 35 million bracket, that's a lot of money. So I think it will be nice to have that corrected and maybe even proofread before it's sent, if this is the final document. Secondly, community health services hasn't changed any spending in the 3-year period, but my understanding is part of the whole reorganisation of the trust is to increase the level of community health activity across Calderdale, and one would have assumed during that period of time would have been getting ready for that and investing money in that, but we don't seem to be. So I'd like, if I've misunderstood that, that's fine. Secondly, you mentioned the population growth, which is significantly more than the McKinsey report. And as a lot of the changes are based on the modelling in the McKinsey report, has any additional modelling been done based on the actual experiences or the actual figures over the last 3 years to see whether some of the assumptions made in the McKinsey report remain valid? And if not, what are we doing about it? Are there some changes? And then finally, I do apologise for the length of this, and this is to do with one of the appendices, so I'll have to get there very quickly. In the appendices, and I think this is page 56, it states a number of priorities have been identified where improvements could be made at pace, and then it just lists one. I think it would be nice to have listed a few more if a number of them have been identified at pace. So I would have been like to have seen more of those where those improvements could be made rather than just list one, unless once again I'm misreading the document. Thank you, Chair.
Right, thank you, Councillor Barnes. Quite a list. Who's going to respond to that, please? We'll have a response from an officer. Sean, do you have anything? Oh, Neil, can I start with you, please? Yeah.
Yeah, so thank you, Councillor Barnes. I think we'll take the format on board and we'll have a look at that. So apologies from that. I'm not seeing many formatting issues on my copy, so there must be a version control. So we'll ensure a more updated version is for you. So with regards to the investment in community services, we've regularly as a CCG recognise the limitations that we have for investment, considering the uplift we've had over the number of years. We would like, and we have an aspiration each year, to invest further in the community services for CHFT. Unfortunately, we've not been able to for a number of years because of the financial conditions that we've been operating in. I think, as Ian would report with social care, you've only got a certain amount of money and you have priorities. And a number of those for the CCG have been around mental health investments, because we've been told to invest in those, and we have the mental health investment standard. So we do have an aspiration. We do use the Better Care Investment Fund to jointly invest with services with the local authority, with our partners. And there is significant sums of money going into different elements, not just the community contract with the hospital. So we would like to invest in that element, but a lot of money is going to other parts rather than that core contract.
Thank you, Neil, for that. I'll come in with Councillor Durans next, please.
Thank you, Chair. I'll just quickly disclose that I'm part of the National Autistic Society Calderdale, and I agree with some others that trying to navigate some systems and referrals can be challenging, particularly if you have extra difficulties and you need an advocate. My second question was around kind of the triangle of needs or idealistics, and again, I've read it all and maybe I've misunderstood, but I kind of understand the ageist care that's there, but there seems to be a lack of preventative care for those that have more severe comorbidities that might not be able to be supported within the community sector because there's more specialist care that needs to be provided, and maybe I've misread that. And the second question is the 2 hours referral to reduce the admission to hospital and then the 7-day intervention. What happens between the 2 hours and the 7 days? Have I not understood that? Because if we're a 2-hour kind of visit and then we leave them for 6.5 days, what if you're already in crisis or at risk of being admitted, what happens for 6.5 days?
Thank you. Michael, would you like to answer some of those points?
Yeah, so on the 2-hour piece, and again, just to be clear, that there's a whole wraparound service that goes around that 2 hours. So we have, as Sean alluded to, a number of services that basically allow people to step down for that 2 hours. So this is really about trying to assess them in the community rather than going to A&E. But if they have ongoing needs beyond that 2 hours, they will be supported by a variety of staff. So Sean mentioned independent living officers, the physiotherapists, the occupational therapists. So there will be a whole variety of roles around that, Councillor Durans, which will pick up that. And then if they have needs beyond the 72 hours and into the 7 days and into the 6 weeks, again, they will be supported by those wider teams in the community. So really it's that 2-hour team, which is a quick response, avoids them going to A&E, going into the same-day emergency care departments, ambulatory care, which allows them to step down into community. So there will be that wraparound service. I think your point then on about the complex needs and the comorbidities, and that's really central to the approach around personalised care planning. It's really not just, we mentioned autism, we mentioned dementia. is not just looking at the diagnosis, but looking at the needs. So when we talk about that personalised assessment, it's a needs-based assessment. It's not a diagnosis-based assessment. That's really, really critical, because your needs are not necessarily associated with your diagnosis. So really the aim for that is to do a holistic assessment based on this person, and then develop the interventions around that, and make sure that, acknowledging all the weaknesses that have been articulated before by Councillor Kingston, is make sure the services wrap around that individual and their needs, rather than the patient having to navigate all around the system to find various bits and those needs, which is the reality of the now. And I don't think any of us would disagree with that. But I think what we're just trying to articulate is we are really, really determined as a system, and noting some of the legalities of those agreements, to move to that model where we work and we wrap services around individual based on their needs, and not the individual specialty or the individual organisation, etc., which is the reality of our health and care system at the moment.
Thank you, Michael. Thank you, Michael. And Sean, would you like to elaborate as well?
Yes, thank you, Councillor Bradford. It's just to follow up on Michael's point, really. Quite rightly, a lot of our time now within the council, my time, is spent on kind of identifying all of those kind of issues that we've got across the system, where care isn't being kind of targeted in the way that it should be, and the shift of resources from the hospital into the community. So there is a whole focus now to make sure that, as Michael has said, really, such as this new model, the urgent community response model, it is about kind of making sure that we are, yes, reacting to where we need to people in crisis and wrapping around, but there's also anticipatory work as well. And one of the things that I didn't mention just in terms of my slide is the amount of work, and Debs would have said this if she'd been on the meeting, that we're doing with public health to make sure that for people of all ages, really, they're staying well for longer. They're words to state, but in fact, there's quite a lot of actions that we're doing behind this work to make sure that's the case.
Thank you, Sean, for coming back on that. And Councillor Hutchinson, please.
Thank you, Chair. As Neil is well aware, we have been seeking this kind of information for quite some time, to see whether the assumptions that are in the strategic outline case for hospital reconfiguration are actually borne out by the out of hospital care, whether the capacity is sufficient to cope with the increased population, the increasing elderly population that we have, which, you know, would in other circumstances would lead to an increased demand for hospital care. And I recognise that the figures that have been produced suggest that 3.9% increase in non-elective admissions up till the start of the pandemic is in line with the assumptions on which the hospital bed modelling has been done. At the same time, the very modest reduction in non-elective bed days, 3.2%, is that strategic outline case also suggested that there could be a 30% reduction in non-elective bed days over a period of 5 years. And I would hope that these figures, together with what's happened during the pandemic, means that we will be abandoning any idea of major reductions in hospital capacity for the foreseeable future, and that those paragraphs that are there in the strategic outline case will not appear in future parts of the planning cases. I think I've got a better format of document than my colleague, Councillor Barnes, has had, because things do seem to line up. But I would say that where it says that there's been a 9.6% increase in the budget for community health services over 3 years, that doesn't take into account inflation. And if you apply the Bank of England's inflation calculator, that suggests that rather than a 9.6% uplift, it's only been a 1.4% uplift, which is much in line with what Neil said about no increase in investment, no real increase in investment in community services. There's a huge amount, there's a huge amount in this report, a number of elements of which would probably do for individual scrutiny questions. And I know we are planning to look at the discharge to assess process at some point in the near future. But my reading of it is that when we're talking about integration of services, seamless services, there seems to have been a huge amount of segmentation, of fragmentation of services. It describes an end-of-life team, a frailty team, a home first team, an urgent community response team. Now, are these teams is the one of these teams within each primary care network, or is the one team that covers all 5 primary care networks for each of these? This looks very much like specific pots of money have been provided by NHS England for very specific purposes that have led to specific services being drawn up. But if that's the case, there must be a lot of duplication of staffing across these different teams, and the potential for disjointed work, between gaps through which patients can fall. Maybe it's just the way it's being described in the document. I don't know, but it would be very sad if what's happening in the community is a greater level of segmentation of services. So I would also like one other point, that when we're talking about managing demand in primary care, the Nuffield Trust produced figures 2 weeks ago that showed that Calderdale has the highest number of patients per GP of anywhere in Yorkshire. And I wondered whether this was intentional because all the services round about are so great. And if it isn't intentional, then what is actually being done to try and address this imbalance? Because it's not an enviable place to be to have the lowest number of GPs per head of population of anywhere in Yorkshire.
Thank you, Councillor Hutchinson. I'll take Neil first, then I've got Michael to help on board as well. So Neil, if you'd like to address some of those issues.
Yeah, thanks, Colin. I'll try and address a couple of them. There's quite a lot in there, so apologies if I do miss some of those. Two spring to mind. I'll do the primary care one and the doctors per head of population. That is an area we've probably been working on as long as I've been in Calderdale, over 12 years now. And we've had success and limited success around attracting additional GPs into the system to set up new practices. So you'll be aware of our alternative primary medical services contracts. We had to cancel those because they were getting to an unaffordable level, and it probably recognises the overall levels of GPs in the system, which is probably where the additional roles investment, which is about £6 to £7 million, which comes into Calderdale over the course of 5 years, which will really help, because a number of our practices, due to shortages of GPs, have diversified into using advanced nurse practitioners, using other skills within their practices to meet that demand. And that is a direction of travel for the NHS to use a wide range of skills within a general practice service, rather than it just being a GP. So healthcare assistants, physios, mental health people are all going to be in practices within your PCNs as we move forward and as we want to work together. I think secondly, you're right, the NHS and a number of areas have been fairly fragmented in commissioning specific services and not integrating them over the years. And I think that's something we've been trying to address through Calderdale Cares. And and I've tried to avoid saying this, but I know I wind Mike up, but that's one of the purposes of bringing our 3CPB. I know he loves that title. We are looking to rename it, but it's the purpose of bringing those organisations together to try and reduce that fragmentation so people don't fall through the gaps. And it's also part of the triangle, and Debs Harkin will have probably explained it a lot better than myself around having that MDT approach, because we do recognise there is a lot of duplication, and we also recognise a lot of people that end up in hospital actually have a lot of health and social services before they get into hospital. So are they right? Are they talking to each other? Can we reduce that to be able to ensure that they get the best sort of care at home before they go into hospital? That takes time. That's a huge culture shift within health and social care services. And Sean and Michael have been working tirelessly with teams to sort of address this. And it's part of why we have the single point of access approach, which is a joint health and social care model to bring those services together. So we recognise there is fragmentation. I think Debbie sort of alluded to it. That is an area we want to strengthen and improve going forward. And that's part of the population health management approach. If we hate to use the word again, but that segmentation, if we can understand who uses resource, how they use the resource, and how we can line it through that MDT approach to streamline it and ensure that people don't fall through the gaps, and that they can move and receive services, whether health and social care, as easy as possible. But that takes time. That is, organisations working together rather than in competition, which we sort of had with the NHS, and is part of the health and care bill that's going forward to break down those barriers so that we do work for the patients at heart. I hope that addresses as much as I could there, Colin.
Can I just ask, when we're talking about people looking after people at home, sort of preventing, meaning that they're less likely to make use of hospital services or need them, or to be able to get home earlier, you really need good holistic care within the homes. The people who are probably most skilled at delivering that and have the wide range of skills and decision-making ability are qualified district nurses who are trained specifically, particularly for that role. And yet there seems to be a studied avoidance of actually mentioning district nursing, either in the McKinsey report or in this report. They just don't feature. They're there in the long-term NHS long-term plan for the urgent care response teams. They feature quite a lot in the long-term plan, but they don't feature anywhere in any of these documents. And I just wondered why not.
Thank you, Councillor Hutchinson. I think Michael's going to come in on that particular element.
Yeah, so thank you, Councillor Hutchinson. So district nurses, if you look on the slide where you've got the diagram of the services around individuals, you'll notice that the district nurses are a core of that. To be really, really clear, the district nursing team are the core of our community healthcare services. They have been in the past, they will continue to be in the future. And a lot of the work that we're doing in terms of trying to make sure that we have the right capacity in our community healthcare teams is related to the district nursing teams and the wider community nursing teams like community matrons, and they're key to this strategy. So the community matrons are key to the strategy around anticipatory care, and the district nurses, as you can have alluded to, Colin, are key to that holistic assessment, that holistic plan of care in the home. Just picking up a couple of your points then in terms of investment and pockets of investment, you're right, you know yourself that with this local commissioning and national commissioning, historically there's been targeted interventions for particular teams. So if we pick the UCR example, and we'll come on to enhanced living care home, we've intentionally not limited ourselves to that national specification. So I think it was Councillor Durans who asked that question about beyond the 0 to 2 hours, what next? So we've said, it's not good enough just to deliver the 0 to 2 hour service. We need to put a full wrapper around individuals. So once they're assessed, then you can support them once they need to step down from that level of urgency. So we don't just take national specifications at the word. We do what's right for Calderdale. And just that piece about duplication of services, both the UCR and the enhanced living care homes are really good examples of where we've removed duplication of services. So the UCR, historically, we would have had 3 or 4 services that sat in that space of urgent responsiveness. So crisis, rapid response reablement, we're basically putting them under a single team. And the same goes for the enhanced help in care home. We had Quest, we had the GPs, we had pharmacy, but that's one team. So I mean, you're right about the kind of pockets of investment. You're right about the points that have been important in district nursing, but we really are trying hard to try and make sure those teams are integrated. We don't duplicate functions, and we're not losing track of the core of what delivers a service in the community, like our district nursing community major. They're critical, not just in Calderdale, but in Kirklees and other places around the country.
And when we've got less than half the number of district nurses that we had 20 years ago, are we actually finding that we can either second people to do the training and hopefully stay in Calderdale? Are we able to manage, sort of recruit to that element of the workforce?
So, I mean, you know, Colin, the wider nursing workforce is a challenge in terms of coming through the pipeline and training. District nursing is part of that. There are some unique challenges around community nursing and district nursing in its broadest context, and that workforce plan that was alluded to before. Community nursing and community teams in general need to be critical to that, because I think a lot of the work that Health Education England and others have done in the past has focused too much on acute, if we're honest, and acute needs and the acute workforce. But there is an increase, and I think the Queen's Nursing Institute, that a number of you may be aware of, they've been commissioned to develop a wider workforce plan for the district nurses. I think the other thing to say that increasingly what we're looking at, and a number of you will be aware of it, it's shared competencies. So you're right, the community nursing workforce, or what was community workforce or community healthcare would have historically 23 years ago would be synonymous with district nursing. But the community healthcare workforce is much wider than that. And it's not just about healthcare, it's about social care. So myself, Sean, Ian, Rowan and Debbie and others have done a lot of work around developing shared competency frameworks and trusted assessment frameworks where it doesn't have to be a district nurse that does the activity that was done 20 years ago. So I mean, it's really critical to understand it's about a much wider workforce, sharing competencies and trusting each other's skills and competencies. Because ultimately, going back to some of those experiences you described before about individuals having to go from pillar to post, trusting in each other's competencies is critical to that, but that does take a wider workforce to support that.
Thank you.
Thank you, Councillor Hutchison. Thank you, Michael, for the explanation. Right, I think I don't have anyone else indicating to speak. I'm sure you'll take on board all the comments that have been raised, and I'm sure we'll see this, you know, at some stage in the future. So thank you for the presentation. Thank you for answering as much as you possibly could this evening, and say we'll hope you'll take those other points away and take them on board. So thank you for attending. Okay, members, so we're on to the item number 8, which is the work programme, which has been circulated. Mike's coming on here and he'll have exactly 30 seconds to add anything to the work programme.
Thank you, Chair. I've had a conversation with Ian Baines and we haven't had a discussion yet about winter plans, and it might be an idea for you to consider having a discussion about winter plans before the winter's over. So what I'd like to suggest is we add probably a presentation, an oral report from Ian and colleagues, I imagine, on winter plans. And we should have included Councillor Swift on the, as well as Councillor Fenton Glynn, because he will come and report on his public health responsibilities as a cabinet member. And I'm going to suggest, if I may, that we move the neurological and dementia items to early in the new year, so we can better plan them because they haven't been planned yet, and so that the week before Christmas you can perhaps have a slightly earlier finish. Thank you, Chair.
Thank you, Mike. And just to let members know, in between these meetings, we've had some really productive meetings with the Adult Safeguarding Board. We equally had the joint reconfiguration of the hospitals the other day. So meetings are taking place in the background to build bonds and make people feel when they come to Scrutiny we're not having to go at them, as you're fully aware. So we want everyone to go away happy. We are your critical friend, as I will continue to keep saying, and we're there to support and add to the benefits. So members, I think that has finalised the items on the agenda. So thank you everyone for their contributions, their valuable contributions. So it's been slightly later than what we normally have, but it's been extremely valuable to take the time to go through those points. So thank you, members, and thank you, officers and organisations, for coming tonight and presenting. So have a nice evening.